Okay, so I'm making the webinar live now.
Doctor, happy birthday.
For 28 years now on this day, I'm unable to think of anything but you, Mom. Because 28 years ago on this very day, everyone had forgotten about you when you needed them the most. The birth of a child must never again be the death of a mother. In India, more than 45,000 mothers die every year due to complications during childbirth. The Manyata stamp of quality ensures that the best clinical practices are upheld by well-trained staff, providing a better, respectful, and safer experience for mothers during childbirth.
दूसरा क्या मिला?
कचार
एक और बेबी?
Exactly.
Seriously?
Seriously.
सही बात है?
Tiago, I'm fast. Tiago, I'm fast.
What vitamins?
You need to take your omega vitamins, you need to take your calcium, you need folic acid.
No swelling? Okay, सही है.
Ay, ikaw ang joke. Yo.
sekhula kangakana kholwanga nokwendela ekhaya atyiwa apha kona
Oh, are you pregnant? Cool. Really cool. Congratulations.
Thank you.
I've got 4 kids.
Really?
Yeah, they're pain in the butt, but you'll do fine.
We can talk about breathing techniques.
इसीलिए कोई भी परिवार नहीं रहता साधन
oh my word hello look how big you are jinamye beta pura kaan rakh do आराम से
when you're pregnant and you have to make a plan and you have to do what you have to do to protect and provide for your young. And it kicks in, and it's a natural instinct, and you've got it. So I know that you're gonna be fine.
Caesar! Dad!
Driver! Where driver?
You can do this. You got this.
Fuck else! Get him
It takes a lot to be a mother. For some, it takes their lives. But thousands of health facilities are saying push. All our health workers say push. All our worldwide partners say push. Let's push until all maternal mortality is a thing of the past.
Okay, a very good evening to one and all present here. I, Dr. Komal Lalwani, on behalf of Nationwide Quality of Care Network, welcome you all to the today's community practice session, which is on Manyata, a quality improvement and quality assurance initiative for private sector childbirth facilities. To invite our panel of experts today, I would like to call upon Professor Vikram Datta. Professor Vikram Datta is the Director Professor at Department of Neonatology, Lady Hardinge Medical College, New Delhi, India. He is the President of Nationwide Quality of Care Network and Vice President of National Neonatology Forum, India. He is the guest editor of BMJ Open Quality South Asia Edition. He is a member of editorial board for International Journal of Quality in Healthcare Communications. He is expert at the International Society for Quality in Healthcare. He is a lead for National Mentoring Group and Technical Resource Group lead for Sustainable Model for Lakshya by Ministry of Health and Family Welfare, India. He is a member of Quality, Equity and Dignity Working Group by Ministry of Health and Family Welfare, India. Over to you, sir.
Good evening, good morning, good afternoon, friends. It's been wonderful to have such a eminent panel today. And I have the pleasure to introduce the distinguished panelists. And to introduce first, I have my senior colleague, Dr. Pompey Sridhar. She is the India Director of MSD for Women, a strong advocate for using market-based approaches to tackle social challenges with over 2 decades of experience. She has offered advisory services for the development of primary healthcare components of national health insurance schemes and contributed to the development of Aadhaar-enabled solutions for healthcare and insurance. She's won the NABARD Award for Innovation from the Union Finance Minister of India in 2012. So welcome, Dr. Pompey. Next, I have the pleasure of introducing Dr. Surajeen. He is the Director of Partnerships at Jhpiego, India, a public health specialist working from Guwahati, Assam, with over 25 years of experience in public health implementation, specialized in the demonstration of history of working with health systems in Jharkhand and India, and has great interest in the health systems, community health workers, childhood nutrition, maternal health, and malaria. He's a community medicine MD from Christian Medical College, Vellore. Welcome, Dr. Suraji, to the Communities of Practice session. Next, I have the pleasure of welcoming Megan Mark Delaney. She is the scientific lead with the Better Birth program at Ariadne. And I think all our colleagues and regular participants to the Communities of Practice session are well aware and have been witness to multiple sessions which NQCN has done with the Ariadne's lab. Megan is a research scientist at the Harvard School of Public Health, and she provides scientific leadership to a portfolio of projects related to improving the quality of care during childbirth. She's a registered nurse and holds a dual Master of Public Health and Master of Science in Nursing, as well as a Bachelor of Science in Nursing from Johns Hopkins University and a Bachelor of Arts in Economics from Skidmore College. Welcome to the Communities of Practice session, Megan. We have with us today, I'm sure all our obstetric colleagues in India are very well familiar with the name of none other than Dr. Narendra Malhotra. Dr. Malhotra is a managing director at Global Rainbow Healthcare. He is director ART at Rainbow IVF. He's been the past president of Federation of Obstetrics and Gynecological Societies of India, a past president of Indian Society for Assisted Reproduction, a practicing obstetrician and gynecologist at Agra. He's been a member and fellow of many Indian and international organizations and has over 50 published and 200 presented papers and has edited 18 books and many chapters and has been on editorial boards of many journals. Welcome, Dr. Malhotra, to the Communities of Practice session. Next, I have the pleasure of introducing Dr. Sucheta Kenjwadekar. Dr. Sucheta is the Manyata assessor and a lead trainer champion, and she is a lead obstetrician at Kamlesh Mother and Child Hospital, Navi Mumbai. She's been in clinical practice for over 30 years and has been the course coordinator at Navi Mumbai CSE and a working committee member of Maharashtra Lakshya Cell GOM. She's been a Lakshya mentor with the FOGSI UNICEF project and a member of Maternal Death Review Committee, Navi Mumbai, I welcome Dr. Sucheta Jhpiego to this course. And finally, I have the pleasure of welcoming Dr. Catherine. Dr. Catherine is the director at Ariadne Lab for the Better Birth program. And I'm sure Dr. Catherine needs no introduction to the Communities of Practice platform. She's been here multiple times before with her awe-inspiring and educational presentations on the Communities of Practice before, and we look forward to multiple such sessions from Dr. Catherine and her team. Catherine is an associate professor at Harvard Medical School with more than 20 years of experience in maternal and child health and epidemiology, and oversees implementation and research for ending preventable deaths of women and newborn through evidence-based scalable solutions. She has led several large-scale clinical trials in areas including prevention of maternal and child mortality and improvement of quality of care. She is a PhD in epidemiology from Boston University and an MPH from University of Alabama at Birmingham. Welcome, Catherine. And now, for the introductory session, I would invite Pompey for the introductory section. Over to you, Pompey.
Thank you, Dr. Datta, and thank you for the opportunity to you and to NQOCN. So MSD for Mothers is a global initiative of it's an MSD pharmaceutical company. Our aim is to create a world where no woman should die giving life. We focus on improving quality of private maternity care, in particular local private providers. And the reason is because we feel that that's the single most important lever to bring about better outcomes and better health for women, in particular, save mothers. As we are aware, in India, approximately 50% of women are going to the private sector across, antenatal care and interpartum and postnatal care. And therefore, ensuring quality across the continuum is important. We cannot do it alone, and we believe that we require a diversity of resources, knowledge, and experience, and more importantly, establishing meaningful partnerships and evidence. And with that, I will invite the team from Ariadne Labs, Harvard University, Catherine, who's been the principal investigator of this piece of evidence, to take over the sessions. Thank you.
Thank you so much, Pompey, for the great introduction, and Dr. Datta for this excellent opportunity to present to the National Quality of Care Network. We're thrilled to be here. As Dr. Datta said, I work at Ariadne Labs, which is a joint health innovation center at the Brigham and Women's Hospital and Harvard T.H. Chan Schools of Public Health, where we envision a world where health systems equitably deliver the best care possible for every patient, every time, everywhere. And we've had the great opportunity to connect with you all, particularly around how do we improve quality of care in the private sector. And as Pompey noted, nearly 50% of all births are in this sector in India. And so we really know that quality of care is where we need to make improvements to reduce maternal and newborn mortality. Our team is focused on the learning agenda, where we understand how Manyata is effective in advancing improvement around maternal and newborn care, how we improve the quality, and what lessons learned need to be applied to the next iterations for this quality improvement work. So I'm actually going to turn it over to Dr. Suranjan Pampamula from the Jhpiego team, who can tell us more about what is Manyata, how does it work, and then we'll share some of our key learnings from the learning agenda. And just a special note of thanks to FOGSI, NQOCN, and of course the Jhpiego team and MSD for Mothers for putting this opportunity together. So Dr. Suranjan, I'm going to turn to you, and Megan's going to share the slides.
Thank you, Dr. Catherine, and thank you, Megan. While the slides are coming up, I would like to say that from Jhpiego, we're really happy to be part of the Manyata journey. And today I'll be describing what exactly we have done in Manyata, and following which Megan would talk about the results that have come because we took Manyata forward. We'll go to the next slide. See, Manyata means different things to different people. To the mother and her family, Manyata is a seal of quality, where she knows that if she gets into a hospital as Manyata certified, that she will get the best quality and respectful care. To the hospital manager and to the hospital owner, Manyata is a certification process. It's a process where they work together and strive to achieve a set of competencies amongst their staff to be able to provide quality maternal and neonatal care. To clinical staffs within the hospital, Manyata is a clinical improvement, quality improvement exercise. They look at it as something to build competencies and to be able to build in systems and a whole team approach to actually take care of mother and children. And most importantly, to the large community of obstetricians in India, which form the FOGSI network, Manyata is a quality movement where they can come together, talk, discuss, and continue to bring in the best practices to all the women in India. Manyata is here today to ensure that every mother and newborn in India is happy and healthy. Next. What we see, what we did to get Manyata on the ground. The first thing, what we did was we helped distill the most important clinical algorithms, the processes, the competencies that matter into 16 standards for clinical practice. These 16 standards were jointly done by the elite technical committee of FOGSI and the government of India. These standards focused on clinical care, the what, the when, and the how. It included high impact practices across multiple domains, within obstetric care, especially in the labor room. We also worked on 10 facility level standards with the government of Maharashtra, getting inspired from Lakshya standards that the government of India came out with. These standards were required to be self-assessed regularly. And then each of these hospitals were expected to ensure that they adhere to them. We also helped create objective assessments and tools that were linked to standards to help them decide, when they've achieved these standards. The second thing, and the next slide, please. The second thing that we looked at, and very important for clinical standards, is to actually ensure clinical competencies and skill buildings amongst the whole team. Now, what we saw was that the sum of the parts, like if I just had trained nurses, it didn't make so much of a difference, unlike having all of them being able to work together and to work in unison. And that's what we got hospitals to do, an integrated team-based training. We brought in the latest techniques in skill transfers, low dose but high frequency, using innovative digital technology, using skills labs that are mobile and can be sent to very many hospitals. We train them on basic trainings for knowledge and skills. We mentored teams to make sure that their environment and ecosystems were feasible for them to perform those clinical algorithms, and continue to do skills and drills so that they would continue to keep those competencies and skills. More importantly, Manyata just only doesn't have clinical algorithms in place. It also embeds within it respect and dignity that go along with quality. In the third step, what we did, and if you can go to the next slide, please. In the third step, we realized that just not building skills of health workers and frontline workers and people within the team, would be sufficient. But more importantly, is to get the hospital management system to back this up. We set up quality circles within each hospitals. We help them solve problems and bring in care. We set up clinical audits and reviews. We gave them SOPs. We set up systems for better case records, human resource management, resource and inventory management. So when we talk about management, we're talking about this whole package that comes in, and just not competency training. Look at the fourth part which we worked on. And the next slide, please. So while we worked with the hospitals, Manyata also worked on establishing a certification process. This certification process was owned by FOGSI, governed by it, except in one state where they have a joint collaboration with the government of Maharashtra and where we give a joint certification. Interestingly, these assessments are done by peers, which means that these assessments are done by people who actually are clinical practitioners, who actually work in labor rooms, and who therefore, can understand both the pain points, what not having quality brings in, and also the gains that having quality brings in. And that's the strong point of this Manyata certification process, that's been built in. And last but not the least, the next slide is, how do we make sure that we spread Manyata across India? How do we make sure that we have Manyata certified sites across the length and breadth of this country? We were able to incubate over 8 hospitals and much more coming up soon, where they would take the Manyata skills, the Manyata package forward to each of these hospitals. Megan, coming next, would be talking about, the actual results that have come from rolling this out in the last 2-3 years in India. Over to you, Megan.
Great. Thank you so much for that introduction, Dr. Suranjan. My name is Megan Marks-Delaney, and I'm a research scientist at Ariadne Labs and a nurse by training. And I just want to extend my thanks to the NQOCN community of practice today for the opportunity to share these findings and to learn alongside with you. We at Ariadne Labs were asked to support the learning around Manyata, to understand the impact of the program, and to support evidence generation to guide its future development. There are many aspects of the program to study, but we focused our exploration in 3 main areas. First, understanding facilities that join the program, then those that succeed in raising quality and gaining accreditation, and then what is needed to sustain the program and to sustain quality after accreditation. Our study and the data today comes from information collected during 184 individualized interviews from a diverse group of stakeholders, including doctors, nurses, program leaders, implementers, and FOGSI assessors who did the final quality assessments at the facilities. We also analyzed programmatically collected data, including data from gap assessments, training scores, and monthly reports submitted by participating facilities. From the qualitative research and analysis of the programmatic data, a few major themes emerged. Understanding why facilities did or did not join Manyata is important programmatically to understand how to target recruitment, but it also helps the larger public health community to gain perspectives on why facility owners and doctors are motivated to participate in this type of program and what needs they have. Engaging the private sector is really a global initiative that is emerging as a really important way to achieve global goals. We know from our quantitative data that mostly small facilities join Manyata, and that's usually less than 30 births a month. Quantitatively, we found that the primary motivation for joining was mostly around access to staff training. We also found that enrollment varied and that additional support and communication may be needed to ensure that facilities start their quality improvement after signing up. I'll tell you a little bit more about these topics. So some of you may be very familiar with the private sector in India, and I'm sure that you know that there's considerable diversity in the sector, both within a single state and across states. It's rarely safe to say that all private facilities do X, Y, Z, but I can tell you a little bit about the facilities that enrolled in Manyata. They were all fairly small, as I mentioned, about 30 births per month, and the main geographies where it's active, it started many of the sites were in UP to begin, and it's evolved so that Maharashtra state is very involved now. And it's important to note that the program has converted to a digital model and is continuing to expand to many additional states. Ooh. So why did facilities join Manyata? Areas of the program that stakeholders found most valuable and most motivating to join the program included things like staff training, since smaller facilities found that it can be difficult to ensure that staff receive regular refreshers and that they don't have supportive infrastructure like many of the larger facilities may have. Another reason was the standardization of care and implementation of protocols. Streamlining supply preparation, many of the facilities have the supplies, but it's really getting them in line so that they can be used quickly and save time and energy. That allowed for smoother work and for staff to better anticipate the needs of what's coming. From our qualitative interviews, the FOGSI affiliation was also a really critical piece of why people decided to join this program versus others. On the other hand, very few stakeholders felt that the accreditation certificate was a main reason for joining. And stakeholders were divided on the subject of financial benefits gained from enrollment. For example, a few doctors felt that increased patient load and thus increased revenue could be a theoretical benefit, but didn't report any actual financial benefits. Although it was difficult to consider as this phase of Manyata was rolling out and implemented during COVID. So many people felt very constrained in raising their fee structure during COVID. One thing to note is that enrollment in this program really varied month to month. So each one of these bars, as you can see, denotes how many facilities per month newly enrolled in the program. And you can note here in the gray boxes that COVID was a major aspect, especially in the data. Most of the data comes from the last few years that I'll be presenting, and that's a limitation of our analysis. I want to turn our attention to understanding how facilities improved quality and achieved accreditation. So you'll see, and we'll talk a little bit more about each of these points, is that adherence to standards was low at baseline among many facilities, but all standards and substandards did improve across the Manyata program. Standards that remained low at the end of the program included those related to complication management, and indeed the cesarean standard, which includes many substandards within it, had the lowest adherence across facilities. Leadership support was found to really foster the accreditation and made it more likely for the facility to continue with the quality improvement and to achieve accreditation. And finally, there was limited data as it was self-reported by facilities on morbidity, mortality, and the patient experience data was very sparse. So we weren't able to find any significant findings from that. So the baseline findings reinforced the need for quality programs like Manyata. The 16 Manyata standards are on the left-hand side listed here. And the bars represent the percent of facilities out of the 405 facilities in the evaluation who achieved that standard at baseline. So for example, starting at the top, you can see that the antenatal care standard was met by just less than 50% of the facilities. While if you look at the complication-related standards at the bottom of the graph, down here, you can see that fewer than 10% of the facilities met the standards of PPH, eclampsia, newborn resuscitation, and cesarean deliveries. Overall, each standard was met by only about a quarter of facilities, and this is baseline only. But improvements were seen across all of the standards, across all of the models, including both the in-person model and the virtual model. In this slide, you can see each of the 16 Manyata quality standards and the upward trend of each of these lines, with baseline starting here. Gap assessment 1 is mid-program and gap assessment 2 is right before accreditation. And this is really remarkable success in meeting the standards of care and improving the standards across all of these facilities. In both our qualitative and quantitative work, we found that supply preparation and process improvement for normal deliveries were the early wins for many facilities. And this was an important point in ensuring that people were motivated to continue in on the program. And the biggest challenges, complication management was the most challenging, both due to the infrequency of occurrence and the complexity of the care required. In some cases, additionally, the documentation that went around complication management was also a big challenge for staff who may not feel comfortable in that area. The cesarean standard had the lowest adherence across facilities, and this is particularly concerning as the cesarean rate was about 60% across facilities. The cesarean substandards with the lowest adherence included the staff ability to understand and implement Robson's criteria, 2, to hold monthly audits and the requirement to review cases of cesarean, and 3, to ensure informed consent of the woman, which is also very concerning and maybe something to quickly address. With all of the effort that's gone into Manyata and improving the quality in the private sector, of course, sustainability of quality is critical. From our qualitative data, 4 main recommendations emerged. The first is to provide ongoing training opportunities as staff turnover and infrequency of complications required additional refreshers for existing staff and a way to onboard new staff and make sure that they become up to date with the processes that were installed in the facility. 2, maintaining quality after the initial accreditation requires some process for recertification to ensure the new processes and practices are maintained. And 3, from the qualitative interviews, many nurses and doctors reported positive changes during Manyata. As Suranjan mentioned, the quality circles that existed there were really positive. And keeping such practices requires additional support for facility leadership to understand how to maintain those structures. And finally, many stakeholders reported the heavy existing burden of documentation just overall, and then the additional burden that came along with Manyata. And so really trying to consider how to streamline the documentation is key. And many of these recommendations are already being implemented and acted upon. And so we should see these incorporated very quickly. It's a very active team. Here's a quote from one of the nurses who participated in Manyata, emphasizing the importance of ongoing training. And then while there's a wealth of learnings from Manyata, I think the 4 main takeaways are really to emphasize the perceived value during recruitment, especially providing ongoing training opportunities and process improvements. 2, to develop additional strategies to improve complication, especially those related to cesareans, PPH, eclampsia, and resuscitation. 3, given the diversity within the private sector, it's important to offer options. Facilities have different strengths and skills of staff, so offering different levels of support or types of support may help best address the facility needs. And finally, offering post-certification support. And as I mentioned, Manyata is moving towards this both in ongoing recurring training opportunities and accreditation, reaccreditation opportunities. In closing, I really want to thank the Jhpiego, FOGSI, and MSD for Mothers team for their close collaboration in interpreting these findings, as well as all of the Manyata collaborators who continue to strive to improve Manyata and ensure quality in the private sector. I'd now like to turn it over to Dr. Malhotra, who will share his experience with Manyata. Thank you so much.
A very good evening to all of you. It's indeed a pleasure to be here on this Manyata session. We all know that Manyata certification is an initiative of the Federation of OB/GYN Societies of India, that's FOGSI, and it aims to reduce preventable maternal and newborn morbidity and mortality both. Now, we all know also that private sector plays almost 50% of the burden of childbirth is provided. And we also all know in the 2-tier and the 3-tier cities and villages, there are gaps in quality care which need to be addressed in all these private healthcare facilities. And FOGSI was very, very keen to bridge these gaps and bring out a program, roll out a program on how we could do that. Manyata initiative, which was launched in 2013 by FOGSI when Dr. Hema Diwakar was the president. And we have, I was one of the first from Agra, because Agra ran a pilot project with Jhpiego on how we can do the Manyata training to the small facilities. And we have a small nursing home, not this big one which you see behind me, which is the small nursing home called Malhotra Nursing and Maternity Home, which is 60 years old in maternal care in Agra, over 3 generations from my grandfather's time. So we were doing everything right. We were delivering more than 100 babies a month. And we were 4 obstetricians involved in it. My mother, my father, and myself and Dr. Jaideep since 1986. Before that, the 2 of them were handling the whole load themselves. So we opted for the Manyata training in the first batch as a pilot project. And during a FOGSI conference, the very next, we of course certified and cleared all the standards. But that taught us so much. And it taught my staff how to work as a team. And it taught my staff how to do methodically. The patient would come, respectful maternal care. Otherwise, doing so many deliveries, it's always a rush and a hush to get this thing. So after 2013-14, when we did the Manyata certification for our old hospital, then we went up to this big multi-speciality hospital, which you see behind me. And this also cleared in the first time. The delivery rates here, because it's a tertiary center, very high risk pregnancy center. So the delivery rate was not as high as the small nursing home, but we had a very, very high risk eclampsias, pre-eclampsias, APH, patients in shock and everything. So again, the staff here got trained how to handle them. And in addition, they got the ICU training also. So 2015, we did this. And then the very next year, the Manyata people asked us, now since you're trained and you've been an assessor and you've been a trainer, you've been talking about PPH drills, obstetric drills, why don't you volunteer to be a Center for Skill and Excellence for Manyata? So that is what we did. We have an NGO which looks after women, which is known as Smriti. So Smriti Rainbow CSC was set up in this hospital in 2016-17. And we started training. So we were doing physical training, and then COVID came. And believe me that all the training which our staff got, that helped in COVID also, even for non-pregnant women. So general care, how respectful maternal care, respectful care for COVID patients also improved a lot. So what we found were the benefits to our both institution was that we had a great capacity building and skill for our healthcare teams to handle all the complicated cases. And we had a high impact intervention in delivery care for delivering quality care. So our staff got trained and very trained. Then we found that Manyata was aligned with the WHO standards and the Government of India standards and everything. So naturally, international care quality came to us naturally. So that was it. Then in COVID, we had the flexible training sessions. So we went online. And then the simplified standards and the mentoring approach started. So this streamlined the improvement model of ours and plus the facilities we were mentoring. So this online helped even much more. Then whoever we trained, the contact providers, the experts, through a very robust internet network or a peer network, which we developed. So it was not just myself, Dr. Jaideep, Dr. Niharika, Dr. Shelly, the 5-6 MDs working at this hospital. We roped in 6 doctors from the medical college, 6 leading practitioners from the practice to join as a trainers team in our CSC. And so that people could get a good view of what is happening in the private sector and the public sector. So they started getting, and then we allotted whatever people trained, we allotted some centers to each one of them to mentorship and to answer all the questions. So that was a great help and a great positive thing for us. It also added a very big peer recognition for us. We are Manyata. We are Manyata. And that is what the spirit I tried to put into all the centers we train, that you are Manyata, you are better than the others who are non-Manyata centers, and you will provide better care and you will get better results to it. Then the major thing which happened was that Manyata training, once it finished, we immediately applied for NABH entry level in both these hospitals. And believe me that we did not have to go in for any NABH training. So we did not have to hire an NABH trainer and pay lakhs of rupees. What we learned in Manyata only had to be supplemented with the physical structure which the NABH qualifies. And within 3 months or 4 months in 2015-16 or I think 17, we got the Manyata entry level. And as soon as we got the Manyata entry level, then Ayushman Bharat and then insurance payback increased and everything. So Manyata helps smaller hospitals get NABH accreditation, especially the entry level ones. Then we had a feedback mechanism for the patients, our own personal and the app on moms, MSD for moms, MSD for mothers, mothers for all those feedback mechanism was given. So that helped us improve patient care, and the patient were very, if you look at our feedbacks, they felt safer, they felt respectful in their childbirth, they felt that they were getting good care in our center as compared to what they got in their previous delivery and all. So private sector, which is offering 50% of the maternal child care to the population of India, we need to train them and bring them at par. Now, for the government, they have Laksh, but the government did not have anything for the private sector. So this FOGSI initiative was a great achievement. Then, of course, our CSC, the Smriti Rainbow Hospital, shows its own achievements. We have now trained over 100 hospitals on Manyata, and this time we have applied for the Rotary International Global Grant, and they will be giving us a grant to train 120 hospitals in tier 2, tier 3 cities in District 3110 of Rotary. So those who are listening and those 8 CSCs, I would advise them that Rotary is a good foundation which will help you to monitor these through Rotarians and will identify the places for you and will of course give you a matching grant. Of course, you have to raise, so the hospital pays half of what they would actually pay for the training. So mine and Dr. Jaideep's, both of us who are running this Smriti Rainbow Hospital CSC now, are very happy. We are committed, and this has taken us on various international, we've been speaking about this in international meetings on how MCH care has to be improved. We have published 3 papers on Manyata effects in the international journal, in the IMA journal, on our experiences in internet. So scientifically also we've kept abreast, and we are now publishing this and presenting this in the World Association of Perinatal Medicine next conference. So that is has been my journey. It is just started, I believe, just 5-7 years, and I hope I will continue and do much more for this great initiative to save mothers in India. Thank you for giving me this opportunity to express myself.
Next, I'm Dr. Sucheta. I'm sitting at Delhi airport and talking to you all. Hi. And it's nice to hear from everyone.
That's the commitment, Sucheta. That's the commitment.
I could hear from Dr. Malhotra. The prior speakers I did not actually was not able to join, but just coming straight away to the point. In Manyata, I have worked as a facility owner. That way I'm a beneficiary of Manyata. I've worked as an assessor. I've worked as a champion. I'm working as a CSC lead. But now I want to express just my experience as a facility owner. Mine was the first facility who got Manyata certification in Maharashtra. Mine is a very small unit, obstetric unit, with an average annual workload of 400 to 500 deliveries every year. And, for a private practice, this is a huge workload. And to manage with the given staff and with the changing, every day-to-day emergencies, it is not an easy job. But Manyata made it very simple for me. It is a structured program. It empowers your nurses because till then they know They are just supposed to call doctors. Doctor, emergency hai, please come. But now they know what exactly to do, how systematically manage all these important emergencies. Their capacity has increased tremendously, and eventually they could get, respect from even the patients. So till then, they were service providers. Nurses were considered just as service providers. But now, after Manyata training, they get respect as health care providers. So that's a big thing. In Manyata, after implementing Manyata standards, we reduced our PPH incidences drastically. We started incorporating and doing active management of third stage of labor in our labor protocol 200%. We started managing real-time partographs to all. We started managing newborn resuscitation in golden minute even without pediatrician coming into picture. So all these were achievements for us. And naturally, our annual average score, was raised than our previous performance automatically, which reflected in practice. Because now patients say, ye hospital mein normal delivery rate is very high, C-sections are very less, only indicated operative delivery, so on and so forth. So it helped our facility. Manyata standardization helped our facility tremendously. I think that's all, because I'm supposed to speak as a facility owner and not as a CSC lead. And I think I'll stop here itself.
Thank you so much, Dr. Sucheta and Dr. Malhotra, for sharing that perspective on the beneficiary as well as from the owner's part. I think Dr. Malhotra and Dr. Sucheta beautifully advocated for the need for other similar facilities, especially small setups, to go for the quality certification and how it ultimately helps in making our national Ayushman Bharat program and the NABH accreditation journey also much easier, and the linkage to insurance for the underprivileged through the Ayushman Bharat scheme as an entry-level NABH certification process gets easier. So I think it's been beautifully linked. And from Dr. Sucheta's presentation, I think we have greater clarity on how mid-size hospitals and larger hospitals can also benefit from this process. Now, friends, I think it is the time to hear the concluding remarks and take the question and answers from our friend Catherine. So over to you, Catherine, for the conclusions and the summary and the question and answer sessions.
Thank you so much, Dr. Datta. And I just wanted to say, one of the things I love about these kinds of presentations is, as an epidemiologist, I look at data a lot and I look at numbers and graphs. And I think what Dr. Sucheta and Dr. Malhotra just presented brings it all to life. The things that we heard in the qualitative research and the quantitative research, that neonatal resuscitation improved. And both Dr. Sucheta and Dr. Narendra, you talked about what were the changes in practices that you saw? What was the value? And another piece that I thought Dr. Narendra brought so beautifully out was this idea of the team. It's a team that makes birth happen well. And so that we have successful and happy mothers and babies and families and providers that are all part of that team that makes it happen. And I think that's what MSD for Mothers and FOGSI and Manyata have been committed to. One of the things that has been a great joy in our work from Ariadne Lab's perspective is this partnership. So not just the team that's happening during the birth, but this teamwork with FOGSI, Jhpiego, MSD for Mothers to make this learning agenda a reality, so that we have this continuous improvement process, which I think NQOCN has been so wonderfully dedicated to, the idea of what does quality improvement look like and how do we make it happen at the front lines of care, at the district level, at the national level, at the global level, which is all we're trying to do, is strive to improve maternal and newborn health. So I think one of the things that I just wanted to highlight is that teamwork. The second is the teamwork that's required of bringing the private sector and the public sector together, so that we talk about care for women and families across the spectrum, because we know people visit in both kinds of sectors. And finally, that this unit, this community of practice that Dr. Datta and NQOCN have hosted is really about creating change. As the video showed in the very beginning, that we all can be the agents of change that make the world a better place. And I think that's a really exciting message. And looking at the adaptation that's been done over this difficult time of COVID, it's been challenging, but moving to an online system, whether that be from Manyata and having an online program that was developed over the past couple of years, or these sessions where we can be all together no matter where we are in the world. So just to highlight that a learning agenda is key. Manyata as a program is successful at creating change and creating improvements in health for women, newborns, and their families, and that we can do that as a global community to use quality improvement to create that change that we want to see. So just a big vote of thanks to Dr. Datta and NQOCN and the team that's here, and especially the presenters today, Dr. Malhotra, Dr. Sucheta, Dr. Srinjan, and Megan. I really appreciate the time. And of course, to Pompey for joining us at the beginning to intro. Dr. Datta, I'll turn it over to you. And we've answered the Q&A in the chat to make sure that people have their questions answered, but still ending on time. So Dr. Datta, I turn to you.
Thank you so much, Catherine. In fact, you have beautifully summarized the role of teams, and that has been effectively portrayed by most of the speakers. Quality improvement, friends, I think the key message from Catherine and the entire panelists takeaway is it's not just collecting data. The key message is not collecting data is a major problem in LMIC economies, but collecting excess data also is a major problem. Like in my own setup, once we counted the labor room registers in the University College of Medical Sciences, and they were nearly 29 to 30 registers which the nursing colleagues were filling. And none of these registers were, really being used to drive the action at the level of the on point of care quality improvement. So that is something which is very, very important. So collect data. And I think the sustainability and the success depends on data-driven action, but only collecting very limited data. As Megan has very beautifully mentioned, that limited amount of data so that there is no overwhelming of the system. Dr. Malhotra, again, I would like to say, sir, the journey which you have said as the Vice President of the National Neonatology Forum, we have just revised the accreditation program under the leadership of Professor Siddharth Ramji, who is our National President. And we have just put that element of quality improvement, which now becomes a mandatory criteria in the NNF accreditation program, which is over 4 decades old. In fact, it was one of the first quality assurance programs in the country. And now we have amalgamated the quality improvement part also into it. We would like and look forward to support from Ariadne Lab at the NNF program also as and when required, and also support from our colleagues in FOGSI in trying to build it as a combined initiative for certifying centers which are certified as NNF accredited, and they have got some birthing facilities. So I think that is the future, that let these both national professional organizations come together and let us use the power of the data to drive action. So with this, I think I have a question, I think, Catherine, which is, Megan is already answering that question. I just had one last question for Megan. What was the time interval between the two follow-up assessments from the baseline? You showed us beautiful improvements across multiple domains. So how much was the time and how long it has been sustained? And is there a national, collaborative type of vision in FOGSI, which will look at a national dashboard for sharing the data across the Manyata facilities? Over to you.
Thank you so much, Dr. Datta. And I can answer the first part of that, but I think the national dashboard, others might have more information as well on that. But really it varied. So initially the program was implemented in an in-person model where mentors from Jhpiego would travel to the facilities and do in-person training and then in-person problem solving. And I think the average time, or the median time for that actually, was about 5.5 or 6 months from start to finish, between the baseline and the final second assessment, and with the middle one kind of occurring mostly in the middle. As the program shifted to virtual, the time needed shortened quite a bit, but we still saw quite a bit of increase. So we shortened to about 3-month time period from beginning to end. So you had the baseline assessment. Within the first month or two, you had the first gap assessment, and then the second and final assessment by these external assessors, by Jhpiego assessors, happened at about month 3. So it was much faster with the virtual model for the timeline.
Dr. Suranjan or Dr. Narendra, can you answer about the kind of the Manyata next phase, or the national dashboard examination?
So what I think is happening is that all the facilities have to give a monthly data to the NPMU, that is the in the FOGSI office, and that is where the national dashboard and all. Now there were some facilities which were very hesitant to provide data because they were very scared that their cesarean section rate would be exposed. But it will be exposed as it is, because we have to give that data to the government. So the government, the birth register has to be filled compulsorily. So that is how we motivated all of them. So a national dashboard is there with the NPMU at the FOGSI office. And that is whenever we have meetings and whenever we meet, we do this. And I think what Megan said, 3 months, we've now even cut it shorter. So 6 weeks training. And after a week or 10 days, so 8th week, a mentor session and a revision session. And if they want one more, then one more at the 10th week, and they go for assessment on the 12th week. Some people don't want the revision, they go for assessment. So they're voluntary whenever they want to take the exam for assessment. So some people are taking it at the 9th or 10th week also. So which is quite encouraging that people are coming forward saying, we are ready, here assess us.
Thank you so much, Dr. Malhotra. I think that clarifies the doubt. So the way forward, it's nice to know that the units are now sharing data without fear, because sir, in the neonatology fraternity, the major problem at the national level has been to motivate the units to share the data, even when we tell them that it would be anonymized. I think that is a big achievement which FOGSI has had. So
pregnancy
I think
delivery data as it is has to be shared with the government. So it is public as it is. So they have no reason to hide it, because they compulsorily they have to put it on the birth register. So it is there, all IUDs, all failed inductions, all indications for cesarean. It goes every month to the government CMO. So the data is available on the public domain.
So that's excellent to know, sir. So I think that, friends, it has been a very informative session. Over 100 people, I think the maximum attendance at time was close to 114, 115 people have attended. And most of these sessions are curated and archived in the Communities of Practice YouTube session. And they are also put up on the web page of the Communities of Practice. Dr. Malhotra, sir, you wanted to add something?
So, yeah, Dr. Datta, I want to say the people from SAFOG countries are attending. I invited them. So we have people from Pakistan, Bangladesh, Sri Lanka, Nepal attending this. And we have offered to them that we can set up a similar program in their countries. I see Dr. Rubina Sohail, the president of the South Asian Federation of OBGYN, taking very keen interest in this. And I think we will devise some way to go into Pakistan, Bangladesh, where it is our duty to save mothers everywhere.
So it's a very warm welcome to friends from the neighboring countries. And here I would just like to mention, sir, that this platform is officially taking care of the quality improvement across Southeast Asia as authorized by the World Health Organization Office for Southeast Asia. And we are actively handholding the teams from Maldives, Bangladesh, and Bhutan into the quality improvement journey. And this has happened last year only, since we turned virtual. A year into our journey, we've been additionally handed over this. So we will look forward to greater synergy, thanks to Catherine and her team, like always, introducing national professional organizations. And we look forward to many more such exciting and enriching sessions, and working together for the betterment of the mothers and their newborn babies. So friends, I think with this, we will end this session, as all good things would ultimately come to an end. And thank you so much for sparing your valuable time. And this is just the beginning. Catherine and I promise that we will have greater synergies between the organizations, and we look forward to working closely into this. So thank you so much. Good night, and wishing all the friends from United States of America and other parts of the country a very pleasant day ahead. Thank you so much. Stay safe. Good night.
Good night. Good night, everyone.
Good night. Thank you. Bye.
Thank you.
Thank you.